joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm so glad that you're here to join us for this webinar entitled Fertility Education for AYAs with Cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. And that includes patients, caregivers, and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. If you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce our speaker for today, please note that your video and microphone are automatically disabled for this webinar. Please enter questions that you have for the speaker into the Q&A feature that's found at the bottom of the Zoom window. Questions will be answered at the end of the presentation, and we may not be able to get to all your questions today, but our presenter will share her contact information at the end of the webinar. The chat is also open. Please use that feature to share comments and resources with other participants or to ask questions of CSCLA. And we ask you to limit chat comments to information relevant to this topic. Estella Barrios is a licensed clinical social worker with credentials in both oncology and palliative care. She is the Adolescent and Young Adult Program Specialist at City of Hope Comprehensive Cancer Center. Her oncology expertise is in lymphoma, stem cell transplantation, and graft versus host disease. She practices actively in the sarcoma and lymphoma outpatient clinics alongside the multidisciplinary team. In her 11-year career at City of Hope, she has provided therapeutic intervention as well as grants and resources for patients throughout their treatment trajectory. Her role as program specialist aims toward ensuring the best possible psychosocial outcomes for adolescent and young adult patients and survivors. And it gives me the greatest pleasure to introduce Estella Barrios to you. Estella, please join us.
Hi there, Kathy. Thank you so much. I appreciate the introduction. I'm Estella Barrios. I'm the Adolescent Young Adult Program Specialist at City of Hope. I'm going to present to you today on fertility and cancer. We will have plenty of time at the end for question and answer, which Kathy Riley is going to help me to facilitate. And we're really going to just dive into fertility risk related to treatment options for cancer. So the plan for today in this next hour is to go over why fertility matters, why this is a topic of discussion, how to start that conversation with your providers and your treatment team. We're going to visit how cancer treatments affect fertility and what your preservation options are. We're going over access to fertility care because it can differ. And then, of course, fertility resources and support. So things that you can take home with you and apply. And then, most importantly, question and answer toward the end. The chat is live now. Feel free to enter your questions there, and Kathy will help facilitate those towards the end. And so, first and foremost, why should we be discussing fertility? It is because over 80% of adolescents and young adults, these are people between the ages of 15 through 39 that have cancer, are now surviving their cancer diagnosis. This is a figure that we're very proud of, and it tells us more about what needs to be done when our patients get to that survivorship phase. Reproductive health is a key part of quality of life for many survivors. So we know this based on the literature, that when our patients get to that survivorship phase, fertility is one of the things that they want to know more about, and it could take a really huge detrimental impact on their happiness and quality of life. Patients who get fertility info at diagnosis do cope better and feel more satisfied with their decision. We know this based on the literature as well. And supporting fertility goals means raising awareness, like workshops we're doing, such as this one, providing counseling, and then of course, improving access to care. So spreading information to patients like yourself to know what your options are. And having more information and research studies and access to specialists, we have this fantastic research protocol with Dr. Irene Sue, whom we are connecting our City of Hope patients with, and really providing goal concordant care, making sure that this fertility discussion is happening at time of diagnosis. And so what does it mean to provide goal concordant care? It means first discussing family planning and what that means to you. Every patient differs. I've sat with patients who have mentioned that they want to have 2 or 3 kids. They don't have any. And on the flip side, there are patients who have mentioned they have 4 kids and they're done. And so that the goal of family planning is going to be different based off of the person. And then education on reproductive risk. This differs from person to person, and then defining the individual's fertility goals. Some patients are okay with moving forward with treatment and understanding their fertility status after, while other patients want to, hold off and do their fertility preservation before. The most important part here is to just have the conversation with your providers. Conversation is key. And there are some instances where the provider does bring it up and you're able to expand on this important topic, but there are going to be times where the provider doesn't bring it up. And so in the situation where, let's say you're in the exam room or you're with your provider going over the treatment plan and the conversation on fertility has not yet started, I'm going to provide you some tools on how to get that conversation going. First is knowing that it's okay to bring up fertility first. Our providers sometimes do well at bringing it up, but always remembering that they're trying to preserve your life first and foremost and getting you to the utmost health. And so if they haven't brought it up, but it's heavy on your mind, then discussing it. These are some of the tips and tricks on how to bring it up in the exam room. It could be a little scary, but I do want to empower you to ask your doctor, how will my cancer and cancer treatment affect my fertility? And based on my treatment plan, what is my risk of infertility? Is it high? Is it moderate? Is it low? What are my options for preservation? And can you refer me to a preservation specialist before we get treatment going? Your doctor might not know all of these answers, but they can refer you to someone who does, either your social worker, a nurse navigator, a fertility specialist at the facility that you're getting treatment. And then, of course, doing your own research. Again, I want to empower you to also look around in your community, understand what your options are, and feel free to get started on some of that process as well. Here at City of Hope, we do have a pretty robust AYA program and a magnificent process where we navigate our patients through from step A to step Z on how to preserve. But if you happen to be at a treatment center that doesn't have those resources, then you can absolutely use the internet at your disposal to get yourself in front of a reproductive endocrinologist or to a sperm bank to preserve before treatment begins. There are some psychosocial considerations to understand. Family planning does matter whether you're partnered or not. There are instances when I'm sitting with a patient who is single and they have not yet had a chance to even think about whether they want children or not. And I do want to encourage you to, regardless of whether you're partnered, consider what your future self would want, and in 10 or 15 years down the line, making decisions for your future self as well. Knowing that it's okay to feel emotional and talking with your care team and specialists about it. This is a very emotionally driven conversation. It can be very heavy, and it's okay to cry and to be tearful with your team. Cost is a big factor in fertility decisions. It's something to be aware of. There are resources for this. And understanding that there are individuals and resources in the treatment center that you're at that can offer you some guidance on how to make it affordable for you so that financial insecurity doesn't become a barrier. And so next is how cancer treatments affect your fertility. There are quite a few components. The first being values. I went over goal concordant care, and sometimes it just not being something that you're interested in. Some patients know. I've spoke to 19, 20-year-olds who understand that they just don't want children. Sexuality is a component, your psychosocial workup, who are your family members or friends that are helping you with these huge decisions, financial resources, your partners, and your baseline gynecological or urological health. These are all things to consider when going into the fertility process and understanding fertility care. There is an impact of cancer treatment on fertility, and it could impact you in a multitude of ways. It could impact you from the cancer itself, hitting your reproductive systems, but also the chemo and radiation that you receive. It's important to know what type of surgery you're getting, if it's going to be a radical surgery, if it's going to be minimally invasive, and then understanding some of the risks related to each type of chemo and immunotherapy that you're getting. These are things that reproductive endocrinologists can assist with, or the specialist at your treatment center. Treatment could also affect your sexual functioning and body image. And so we're going over today in this workshop the multitude of ways that you could be detrimentally impacted in terms of infertility, but libido, desire to have sex, desire to be intimate could also take a hit, just based off of scarring, based off of bodily changes, based off of just what you're interested in. And so these are things that our occupational therapists can assist with, and specialists can also lean in and help with understanding what the barriers are there to get you to sexual functioning that you're comfortable with. And individual factors to consider: age and type of cancer, whether you're 15, whether you're 39, your individual workup is going to be different. Your fertility status before treatment, understanding if you've had pregnancies in the past, if you have underlying concerns of like PCOS or hormonal imbalances, those are all going to play a part. Your desire to have a baby in the future, I've mentioned this a few times. It is okay if you've already understood and decided between your partner or just within yourself that you do not want to have children. But the point is for you to make that decision and not having a provider make it for you. And then fertility preservation options for females. This is a nice breakdown of the many, many options that you have in terms of egg banking or embryo banking. This can take 10 to 15 days. And so this is why we offer a great deal of education and letting individuals know ahead of time that if you would like to go through with egg banking, it can delay the start of treatment, though sometimes if started early, there's no need to delay. There's also ovarian tissue banking, which is still experimental, but it is something that takes place within our younger population of removing either a piece of the ovarian tissue or the entire ovary. Ovarian transposition, which takes place before radiation treatment, a radiation shielding, and finally ovarian suppression, which could be done concurrently with your chemotherapy. And fertility testing for females, it's important to understand that menstruation after treatment doesn't always mean fertility, and so getting a test is important. I've had individuals who've shared that their menstrual cycle returned as scheduled once their treatment was completed, but that doesn't necessarily mean that you're fertile. And so it is important to go through with the full tests to understand. And I am going to line out some of those tests and labs that can be done by your treatment team. Your cancer treatment can cause early menopause if your period does return. And next are the labs, fertility tests that can be done. These can be ordered by your provider, FSH, estradiol, and AMH, and these will be rather telling results of what your current status is. These ideally are done before your treatment begins to gather a baseline, and then when you're done with treatment. And of course, the uterus, cervix, and fallopian tubes should also be tested and checked for pregnancy readiness. So our female patients are in a very unique and special position where it's not only getting pregnant, but carrying the baby full term. And so understanding your body's readiness to carry a baby is very important, and involving your medical team outside of your oncology team, but a gynecologist and a maternal fetal medicine provider can help with these things. So it is important to remember that not all cancers or treatments affect fertility. I know I've spoke heavily on infertility being a major concern. In some instances, in certain diseases, there are chemotherapies that have a very low 10% chance of infertility. And so these are things that your hematologist will inform you of. Your period returning doesn't guarantee future fertility, which I've mentioned, and eggs, embryos, and ovarian tissue can be frozen and used years and years later. So one important thing to note is that going to a fertility clinic, you would want to ask for long-term options. Most standard fertility clinics will freeze for 1 year, 2 years maximum is what I've come across. In the cancer setting, you'll need something long-term, 5, 10, 15 years down the line. And doctors recommend waiting 6 months to 5 years after treatment to try for pregnancy. This varies depending on individual. And again, it's something to discuss with your provider when you decide that you're ready to get started. Using contraceptives, if you're not ready to get pregnant, is still highly recommended. I've come across instances where if you're for sure that there is concern of infertility, some have the initial instinct of dropping contraceptives because there's no chance of pregnancy. And we like to recommend against that. It's always important to have safe sex. And children of cancer survivors are not at higher risk of birth defects or cancer unless there is a known genetic mutation involved. This is important to remember for some of my patients who have Li-Fermini syndrome, who've had genetic testing. And this is something that you would discuss with your fertility specialist and with your genetics team. And so these are the fertility preservation options for men. The standard of care is sperm banking, and this could be done relatively quickly with a turnaround of, same day, next day. It is encouraged to do this before treatment, and we do have various sperm banks in the Southern California area. The institution that you're getting treatment might have a pre-established partnership with a sperm bank. And again, it's important to mention to the bank, if you select to find them on your own, that you are a cancer patient so that you stand out from the elective people that are coming in to bank for other reasons. You would let them know that you have cancer around the corner, treatment's going to be beginning soon, and so you're not able to wait 1, 2, or 3 weeks before banking. Letting them know of your medical situation will help you be expedited to sooner appointments. And then testicular tissue freezing and radiation shielding are things that are done either within your treatment center or in a local fertility clinic as well. The testicular tissue freezing is more so for our prepubescent individuals, and then radiation shielding is for those that are with radiation on their treatment plan. And this is something that's a shield that will protect you from scatter radiation or from radiation hitting the testicle area, and it will keep you safe. And so fertility testing for males, semen analysis is a standard, and we recommend it when patients are done with treatment. This will help to understand how the sperm count, the shape, the movement, and possible infections. There are sperm function tests, hormone tests, urinalysis, and genetic tests that are all recommended for males. And these are things that can be done both before and after treatment or in the middle. And so important things to remember for males is that not all cancers or treatments affect fertility. And sperm banking is the easiest and most affordable way to preserve your fertility as a male. And then waiting 6 to 12 months after chemo or radiation before trying to conceive is what's recommended. And sperm production can return right away, or it could take several years. And this is important for our male patients who sometimes could be a bit discouraged when doing a semen analysis when treatment is done, seeing that the sperm count is low and feeling a bit defeated. But over time, there is, depending on the treatment type, there is chance for sperm recovery. And so repeat semen analysis is recommended. And the use of contraceptions, if you don't want children, or if you think you're infertile, again, we highly encourage safe sex. And children of cancer survivors, again, we'll give this bit of information, are not at higher risk for birth defects unless there's a known genetic mutation. We mentioned this 2 times because there have been instances of young adults who have verbalized concern that they're just not sure if they want to have children because they don't know if they're going to pass their cancer on to their kids. And so we do want to give the information that that is not necessarily true. And it is based on each individual and your genetic workup. Alternatives for family planning. We threw this slide in because it's very important. It's something that came up last year. Knowing what your options are and knowing that adoption is a beautiful alternative to having biological children. It could be a great option for either the individual or the couple. And in addition to adoption, there's also donor eggs, donor sperm, and embryos. Oftentimes, many of the banks that we partner with, or if you yourself have gone to a sperm bank, they tend to have donor sperm available as well that could be used. I've had a few instances of patients who unfortunately went through the sperm banking process and found that they didn't have sperm or that their sperm wasn't swimming. You do have the option to access donated sperm so that you can build a family. And then surrogacy. For our female individuals, I've mentioned patients sometimes as a woman not being able or your body not being ready or capable of carrying a child full term. Understanding the ins and outs of surrogacy and having another person carry the baby for you. And then fostering to adopt, finally, understanding that there are county options, either temporary foster care or full foster care with the option to adopt the child afterward. And then access to fertility treatment. This does differ depending on where you're getting your treatment and what state you're in, but it was absolutely a win in the oncology setting where legislation was passed that supports patients who have been recently diagnosed and need to do fertility preservation. This legislation shows in the next slide that there are states that will protect you and require that your insurance cover the service. I do encourage you to screenshot or save this slide depending on which state you're in. California does have active fertility preservation coverage. There are some states in the sand color that have inactive legislation, and then the blue is still active and not completely known yet, but this data is from 2023. We do hope to get updated information very soon. The SB 600 bill is available for everyone. This is public information. And again, I encourage you and empower you to have this with you. There have been instances where even if you're calling insurance, I know when I've called insurance, sometimes whoever is on the line with you might not be as familiar with what the latest legislation is. And there can be a bit of pushback that you might experience. And so I encourage you to have this information in front of you or share it with your team so that you're able to advocate for yourself, especially if you have a commercial insurance that is based out of California. That is almost immediate and known that you'll be able to activate this SB 600, but it is a matter of you knowing that it exists. And paying for treatment, these figures are rather high. It is very expensive to have preservation. And so understanding that there are financial aid options to help cover whether it's egg freezing that is over 10,000 in some instances, embryo freezing, and the list of that I shared in the previous slide of, what works best for you. Sometimes it could depend on what the cost is. There have been patients who decided on the preservation method based on what they were able to afford, and that is completely fine. The pediatric options for ovarian tissue cryopreservation is a similar figure, and then testicular tissue cryopreservation for our pediatric males, we don't have that information, but I do want to draw your attention to the post-treatment options. So understanding that if you weren't able to do preservation fully, these are some of the prices for donor embryos, donor eggs, donor sperm, and then the cost of surrogacy. And in the next slide is some fertility resources. Again, I encourage you to share or screenshot this as well. Many fertility clinics in the community will have a Livestrong partnership. And so they'll have a financial aid department or a financial department that will educate you on some of the options you have and discounts that you can access because you're a cancer patient and you're going through the process and because it's time sensitive. And finally, I want to thank you for your time and attention today. And this is a very important topic, and I'm happy to answer any questions that you have. And Kathy's going to help to facilitate those.
Great. Thank you so much, Estella, for that meaningful presentation. I learn so much every time I hear you speak. So we really thank you for being here today. And I invite everyone to go ahead and enter your questions into the Q&A. I see they've been coming in, so keep doing so. And we also have some from registration. So we've got a lot of questions for you, Estella.
Perfect. I'm ready.
So first of all, can you talk a little more about the mutagenic and teratogenic risks of the various treatments? Many worry about being at a much higher risk of having a child with malformations or developmental disorders, whether they try to conceive within a few months after remission or a year or two later.
That is a good question. I would say one of my recommendations is to always involve a maternal fetal medicine specialist if you're done with treatment and would like to get started with having a family. The maternal fetal medicine specialist is not able to deliver a baby, but will work in conjunction with a gynecologist and will be able to assist with what we might call a high-risk pregnancy. And then again, with the genetics team, having them involved in understanding any genetic predispositions and explaining a bit further what the concerns are.
Great. When you said the 6 months to 5 years after treatment to try to conceive, what are those factors that influence whether it's closer to 6 months or 5 years?
It does depend on the individual's treatment that they received and the type of cancer that they had. One example that comes to mind is if a patient had a transplant and is curious about their ability to carry a baby. There is the risk of a GVHD flare and not being able to fully, carry the baby because the skin is not able to flex and expand. And so understanding that there could be risks to the mom again with pregnancy, that it happens too soon after treatment is done. The most important takeaway is to involve your hematologist and oncology team before trying to get pregnant. The time frame will differ depending on the individual.
Right. And this next question about insurance providers was covered in your talk, and the individual thanks you for that a little bit later on. We have another question about birth defects. Someone who's confused by the children of cancer survivors not at higher risk of birth defects. And they quote from some research that chemotherapies frequently target and damage DNA, causing mutations or genomic instability, a major hallmark of both cancer and aging. However, there are numerous types of chemotherapeutic drugs that are genotoxic and interfere with DNA metabolism in different ways, each with their own biodistribution, kinetics, and biologic fate. So could you talk a little bit more about that, about the children of cancer survivors not at risk for higher birth defects?
That is a good question. I think I'm going to have to defer that question to the individual's medical team. It sounds very specific. I wish I had the answer, but I will say if there's a question like this that comes up that is on your mind, to discuss it with your team. And it's okay to call a meeting with them and mention that you have this very important concern and you want to know more, and keep yourself informed.
Yeah, great. Thank you. Is there a significant cost difference for each of the alternative family planning options? Someone is wanting to know, fertility, versus adoption.
There is a very big cost difference. With adoption, we can start there. Private adoption could cost a lot in comparison to county adoption. That does have a lot of built-in education and resources. It is okay to explore both concurrently to receive some of the education and information from the county for free. And then decide to move forward with a private adoption. Both of them have their own separate lists of pros, and the cost will vary, but the more affordable economical route is the county option and fostering to adopt. The preservation piece of accessing, let's say, your embryos, accessing your oocytes, that will vary as well depending on the state that you're in and the county, and understanding whether you preserved eggs or oocytes. The price is very different.
Great, thank you. And moving in a different direction now, where can one find a quality maternal fetal medicine specialist, and what association or directories would be able to find that specialist?
Oh, great question. There are a couple of options. If you have an established prenatal doctor who has been overseeing your prenatal care during pregnancy, they sometimes will have a partnered maternal fetal medicine specialist that can take care of you concurrently. There's also the option of going through your insurance and speaking to them about what your situation is and using their website to find a specialist that's in your area. The third option is standard research online, looking for a local maternal fetal medicine specialist. There are locations and clinics I've come across in West Covina area. San Gabriel Valley area happens to have quite a few.
Great, great, thank you. This next question is from the healthcare provider lens. How do you handle disclosure to patients asking you about your own fertility, if you have children or not? So that's the first part of the question. And then second part, what is the best strategy to support your patients with encountering those around them who are fertile, like a friend, family, or therapist?
That is a good question. It's a two-part. So the first question, in my over 10 years, I've not come across a patient who has asked about my individual fertile status or if I have children. If a patient asks, I'm happy to disclose. I feel like it does show that the individual in front of me is wanting to connect. They want to know that it's a human being that's assisting them. They might want to know how I know what I know and whether it's from personal experience or professional experience. And so I am happy to share that with the individual, absolutely, if it's going to help them, which most of the time it is. And for the second question, can you ask it again, Kathy?
Yes. What is the best strategy to support your patients with encountering those around them who are fertile?
So there have been some instances where, and it could be true for many of our audience today, where it is isolating, understanding that you might have issues with fertility or might be with certainty infertile once treatment is done. And so understanding and surrounding yourselves with peers who get it, peers who've been in the fertility space, who discuss this very important topic, who maybe went through the preservation process, and sharing stories with them, taking care of each other and kind of supporting each other through this process can very much help the individual's mental health and help with coping, knowing that you're not alone and that it is something that is a big problem and can be difficult to cope with.
And then from your experience, can you speak to whether the infertility and challenges to the fetus probabilities are lower if the male is the one who had cancer and successful treatment versus the female who was treated? And then goes through the work of getting pregnant and carrying the baby. So speaking to whether or not um, uh, those kinds of challenges are larger for male versus female.
That's a magnificent question, and I would like to know the answer to that as well. I would say that is something to save for the provider or a specialist to get a true answer. And I would like to know the answer as well. I'm going to write that one down. Thank you, Kathy.
Yeah, that's a good one.
It is.
And then again, from the healthcare provider perspective, for those clinicians who are interested in conducting assessments for known embryo donation, sperm donation, or egg donation, what agency is the best to use for training on this?
There are, for donation, most sperm banks do, we could start with sperm banking. Most of them do offer a donation program. And Fairfax is one of the local sperm banks that has a long-term program. There's also Southern California Fertility, that is a location in Orange County. And most of the time you can get this information over the phone and let them know what your interests are, what your questions are. And I have found with sperm banks specifically, you get a live person on the other side of the phone that's trying to help you with the process, especially if you identify yourself as someone in the cancer setting who wants to know more about sperm donation.
Great. And then would you say that there's much variance in quality and outcome between egg freezing and sperm freezing and other reproductive options in which you get what you pay for, depending on the price the fertility clinics provide? And then how do you know which ones are better?
That is a good question for the specialist that is in the clinic. Most of it is something that is very scientific, understanding if there's any damage to the sperm, understanding what the health of that sperm is that was saved, and understanding the eggs that are frozen, were they mature eggs and how many. And this is why a specialist team is involved when you're accessing your sperm or eggs when you're done with treatment. That is the role of the specialist, to let you know some of that information and what the risks are from that point.
Yeah. Yeah, and this individual is saying, yes, they were wondering if the machines they use to freeze are all the same or whether some are better, but sounds like that's a question for again, for the specialist.
Yeah, it does differ a bit. Some of the more updated sperm clinics will have more updated equipment. And we have come across, it does differ in terms of analysis and being able to truly look at the sperm and see whether it is damaged or whether it's mobile, and knowing what they're freezing before it's frozen. And then the thawing process also matters significantly, and understanding that some sperm will die in the thawing process. And so it being done appropriately is very important. I will say, as a patient, you always have access to your sample. And so you very well could go to a sperm bank and ask to have it withdrawn and take it home with you. And so understanding the risks of that are very important. And the sperm bank will inform you of that.
And then, so another follow-up questions, the newer machines then do a better analysis. Is that a question you can comment on?
I will say that an updated, a clinic that is up to date, that has specialists that specifically only work with sperm and sperm analysis and are a standalone clinic, tend to be more preferred than a location who doesn't do them as often, who might not be able to interpret semen results. Understanding that when you have the analysis done, it takes a separate specialist to read the analysis to you and interpret what it means.
And then going back to your comment about taking the sample home with you, under what reason might someone consider taking their sample back?
There have been instances where if the individual moves to another location, let's say if they're in California and they move to Texas or New York and they want to take their sample with them, they could very well take it to freeze it in a location that they're at. There is a price for withdrawing it, and there's an option to have it shipped or transferred directly to another sperm bank. So understanding if it's thawed, then there will be damage, and it could negatively impact the sperm. But that is one example, if someone moves. Another example is if the individual was able to freeze very, very strong sperm and wants to use the sperm for IUI, they are able to withdraw the sperm at that point as well to use it.
And what is IUI?
It would be when the sperm is inserted into the vagina to achieve pregnancy. The easiest, least scientific way to explain it is the turkey baster method, which is a few of my AYAs have mentioned it to me, and they said, that sounds like the most affordable. I think I'm going to go with that route. But it is very much an option. They have at-home kits. The science is very much catching up on what they can do with sperm at home. And I do add the disclaimer that if you don't have the professional with you to guide you through the process, there can be sperm that's lost, unfortunately.
Yeah. And then moving in a little bit different direction, this is a question about conversations. Someone is asking from registration recommendations for how to manage approaches if patients and caregivers disagree about fertility preservation or about having children.
This is a good question. It's twofold because it does depend on how old the patient is, right? AYA does extend from 15 through 39 years old. And so my approach will be different with a 15-year-old versus someone who's 38 and 39. With our older AYAs, really empowering the individual to make the decision on their own. It's something that is very much a personal goal of whether they would like to have children or not, whether they want to preserve, whether they want to delay treatment for a couple of weeks so that they can save enough sperm or save their eggs. It's very much an individual process. And that's part of my role as the program specialist here, is to create that space for the person in front of me and to kind of carve out time for them to sit and decide. If they are partnered, then looping in the partner on the second half of that discussion, bringing in their spouse, but it always starts with the patient and what they want. And then for our, adolescents, the patients that are 15, 16, 17, involving their family. And a parent is in the room discussing just what the steps are. There have been instances where 15-year-old may not have masturbated before, and now they're asked to do that in a sperm bank with the purpose of saving the sperm. And so that could be challenging for, a young person who's also just been diagnosed. And so walking them through that process and making the decision, them with their parents is very important. And reminding them that as a 15-year-old, they're not having children in that moment. They're making the decision for themselves 10, 15 years down the line when they're 25, 35.
And then someone is asking what the acronym AYA stands for, and that's adolescent and young adults. And you said again, 15 up to
15 through 39 years old is the adolescent young adult age range.
okay.
AYA is the shorthand.
Yeah, yeah. And I think sometimes when we're so used to that, but it's
Yeah,
adolescent.
we forget. I'm glad. It's a good question.
It's a great question. Um, Someone is asking, is talking about fertility in survivorship too late?
No, it's never too late to discuss fertility, especially if it's something that has come to the surface for you. It means that it is something that deserves attention. And in survivorship, whether it's the provider or it's the patient, it's okay to address. And if the patient feels that it's not important to them, they'll say, I've already decided, or I've preserved, or I don't want kids. But I'm assuming a provider is asking this question, or a clinician. It is always okay to bring it up and let the patient tell you if it's not important.
Great, that's great advice. Another question, I think this is again from the provider perspective. How do we discuss fertility with adolescents and young adults while keeping in mind different cultural nuances of each patient?
That's a good question. And it does differ whether it's someone who's an adolescent in their teens or whether it's someone on the older range. But just approaching with curiosity, understanding where they're coming from, what their preferences are, and respecting where the patient is. I've had an example that comes to mind of an individual who felt like it would be against her religion to involve specialists and freeze her eggs and go through the process with science so heavily involved. She felt that she wanted to rely on her faith and really just follow what she felt was right for her, minus the involvement of fertility specialists. And that is the right answer for her, and really respecting where she was coming from and giving her that space and control to make that decision for herself.
Great. And then one final question, and you may have covered this in your last slide. So if you did it, it's probably worth reiterating again. But guidance that you have on grants to cover with the cost of egg freezing for oncology patients.
Yes, there are quite a few. We have a fantastic partnership with Megan's Wings, and they have truly helped us with so many fertility preservation grants. And they do have partnerships with different hospitals, and so there is a chance that the hospital that this individual is at has access to that agency. There's also countless agencies that are online that we've accessed, depending on where the patient lives, depending on the type of treatment that they got, depending on the cancer that they have. Much of it is changing, which makes it a bit complex and difficult to keep up with the options. But speaking with your social worker or specialist on what grants you have access to. There can also be internal policies or financial aid that you can access in your hospital. City of Hope does have a reimbursement process to help patients get funds back that they've paid toward preservation, just to lessen the burden.
Yeah. All right, well, thank you so much. And we are not able to get to all the questions today, but Estella, maybe you could share. I know it was on the slide, and maybe you could type it into the chat as well, your contact information. And then if, again, if you would like a copy of the slides, you can see in the chat, you can email info@cancersupportla.org. And then I'm going to ask Abby to share our closing slide for us. And while you're doing that, Estella, I want to thank you so much for presenting today, for staying with us and answering so many of our questions. It really was a rich presentation and discussion. And I want to thank all of you who participated today and asked so many meaningful questions. We really appreciate your engagement with us today. If you would like to learn more about Cancer Support Community Los Angeles, please visit our website, and that is cancersupportla.org. If you have any questions, again, email that info account at cancersupportla.org. And then we're inviting you to join our young adult game night, which is bi-monthly. We happen to be having our next game night coming up next week on April 22nd. It is 5 p.m. Pacific time, 7 p.m. Central, and 8 p.m. Eastern time. If you would like to join us, please scan the QR code on this flyer. You can also reach out to us if you're having any trouble with that code. Thank you, everyone, for joining us today. We hope to see you at one of our upcoming educational webinars. Thank you so much. Have a great day.